delighted to welcome our speakers. Our first speaker is Louisa Degenhardt. She's the Director of Research at the National Drug and Alcohol Research Centre at the University of New South Wales. The floor is to you, Louisa.
Thanks very much, it's lovely to be here. I've never been to Cape Town before, and it's a beautiful city, so really enjoying it. I thank you very much for the little promo from Rick Ortiz in the session previously. What I'm going to be presenting today is a very brief overview of a systematic review that a very large group of us has been undertaking now for the past 2 or 3 years. Just want to acknowledge the fact that I'm presenting this work on behalf of a very large group of people. Definitely want to give a very important shout out to the team back at NDAC where I work. We have a large group of research assistants, research officers, PhD students and postdoctoral researchers who've been really important and crucial members of the team for this review, but also a network of people in universities and in government, non-government and UN organisations around the world that we've very much enjoyed collaborating with on this review. As I said, it will be a brief summary of this review. It's currently under review at IJDP. No formal updates at this point, but hopefully an update soon on the result of the review process. And also just wanted to flag that Tom Santo will be presenting on the companion piece to this, which is summarising the evidence on availability and coverage of interventions in carceral settings globally. So we've essentially the intent of this review was to build on using the methodology and the logic of reviews that we have done that have focused on people who inject drugs and other populations of people who use drugs. Systematic reviews that really were done in community settings. What we wanted to do in this one was apply those same methods and those same approaches to undertake a systematic review of the state of the epidemiology of injecting drug use among people who are incarcerated and of the prevalence of HIV, hepatitis C, hepatitis B and tuberculosis among people who are experiencing incarceration. Today I'll be giving you a brief overview of what we found in terms of the levels of injecting drug use and of infectious diseases, but we collected a wide range of other information during this review, and the intent of that is when you undertake a review of this scale, we figure we may as well collect as much information from the eligible studies as we can. The intent of that is that there will be other more focused pieces of work that come out of this afterwards. But what we also want to do is to develop a database that can be useful, particularly for people who are working on mathematical modelling, looking at the impact of changes in both the epidemiology and in coverage of interventions. And a lot of that work is being led by our collaborators at Bristol University and UCSD, particularly Peter Vickerman, Natasha Martin and Jack Stone. So just to give you an overview of the methodology of what we did, essentially we've searched in multiple different ways. So we do a standard peer-reviewed literature search. We also developed and built on methodologies for searching the grey literature online, looking at websites, so both from international organisations and country-based organisations, both in health and from the correctional side of things in government agencies. We also used our network of people that we know and organisations and agencies that we're aware of that we know are either involved in working with people who are incarcerated or delivering interventions, or who are themselves collecting data that might be relevant to our review. And that include organisations that include WHO, UNODC and UNAIDS. Some of those people are here today. And we use the methods that we've used in previous reviews, looking at injecting drug use and HIV among people who are in the community, to make the same kinds of estimates for people who are incarcerated. So this is it's a big logistical exercise, and it involves screening of a lot of information. Tens of thousands of reports and papers were screened. So what I'm going to present, hopefully the numbers aren't too small on the screen. If they are, I'm sorry, but I'm very happy to share information with people on these. There'll be a series of these kinds of tables. This is just to demonstrate a number of things, so the logic will be the same for the infectious disease. There is variation in the availability of information, so that is in the left-hand column in terms of the number of studies that have evaluated the prevalence of lifetime injecting among people who are incarcerated. When we looked at pooling and made pooled estimates of the prevalence of lifetime injecting, there is variation geographically and among men and women, and the differences between men and women can flip according to the region. So what you can see, for example, in Australasia, and this is driven by data from Australia, the prevalence of a history of injecting drug use among women who are incarcerated is much higher than it is among men who are incarcerated, but in many other regions worldwide, the reverse is true. But overall, we estimate between 1 in 10 and 1 in 8 people who are incarcerated to have injected drugs globally. So this is just to show you both the variation when you're looking at data that are available, so darker colours means higher prevalence, but also the large gaps in data that exist in terms of having no studies that have estimated this in countries in many parts of the world. So this slide here is presenting information on the prevalence of current hepatitis C infection. Again, there's substantial variation in the levels of current HIV infection geographically and among men and women, but globally around 11% of people who are incarcerated, we estimate, have current hepatitis C infection. And again, showing variation both in the availability data and very great variation in prevalence, which reflects the variation in prevalence of injecting among people who are incarcerated. Here you can see prevalence of HIV. Globally, we estimate around just under 4% of people who are incarcerated are living with HIV. There is more data available, and you'll see there's a lot more data in African countries, particularly compared to the other indicators. I'm not presenting data on hepatitis B, but we have generated that just for the purposes of time. Here, this is the prevalence of tuberculosis. What you can see is there are more gaps in data availability, and prevalence levels overall are lower than they are for some of the other infectious diseases, but there is still substantial variation geographically. And in terms of the data that we identified, there was substantial issues in terms of bias of the estimates of the data that have been collected. They're often subject to substantial issues in terms of the extent to which it's a valid estimate of prevalence, typically because of the way in which the samples themselves were assembled, and how representative they were of the overall incarcerated population, and often because there was very poor description of both the settings where people were recruited from and the characteristics of participants themselves. So just to summarise, we estimate that around 12% of people who are incarcerated globally have ever injected drugs. This is around 1.35 million people globally. And you can see there that the estimates globally of the number of people who are living with HIV, have current hepatitis C infection and have active tuberculosis. What you can see there is just the global summary. We've also generated those estimates by region and country around how that compares to the general population. And you can see there that, for example, with injecting drug use, it's around over 50 times higher prevalence among people who are incarcerated globally than the general population, for example. And we demonstrated clear variation in the extent of elevation in risk of both injecting drug use histories and of infectious disease geographically. But all of those data can be used to inform service planning and policy development. As I mentioned, there are limitations in the evidence, which hopefully were clear in the maps that I showed you, but in the review that we present, everything is presented at country level and you can see the source of all of the data. And the intent of that is to show people where we have obtained information, but also where the data gaps are. But clearly the existing data do point to a very high burden of infectious disease in carceral settings globally that really do pose a challenge for global disease elimination efforts. There are a range of ways in which this points to things that need to occur in order to address this. Many of those will be touched on by Tom Santo in the next session, where he actually summarises the evidence on interventions that can address these things, particularly around routine screening and prevention and treatment for infectious disease, as well as services to both prevent drug-related harm and treat opioid dependence specifically. But there's also a need to link, as Rick mentioned in his presentation earlier, to look at continuity of treatment, both for people who are drug dependent, but also for people who are living with HIV or other infectious diseases, to continue to receive treatment post-release from incarceration. And of course, there's a real need to reduce unnecessary incarceration in the first place. And with that, I'll finish my very quick review of the review. Thank you.
Thank you so much for the excellent presentation. I should have said it before the session, you have to post your questions in the app. So if you have any questions, can you post your questions in the app so that we can see them coming up on our screen? Or if you have any questions, you can also raise your hand, perhaps. Might be more difficult with the mic. Any questions to this presentation? We take 2 questions from the audience.
I have one question. If I don't see a hand, there is a hand back there.
Could you type? You have to type your questions in the app.
No, until we get the microphone, I think I can ask my question, perhaps.
Sure.
I saw that there was first of all, we appreciate all the work behind to synthesize this data, and I like that we have the data also by gender. I have seen a big difference in HIV prevalence between men and women, if I'm correct. I wonder if the differences that we see in prisons reflect differences in the population outside prison as well in these particular regions. Are they in accordance with that?
Yeah, look, I suspect it's both differences in prevalence in the general community, but also a difference in the kinds of people who are at risk of incarceration in different countries. So, for example, in Australia, there's a much higher level of a history of injecting drug use among people who are incarcerated in Australia, much lower in some other settings, but the prevalence of some infectious diseases likely is varying because of varied risk factors for becoming incarcerated in the first place. Yep.
I think the mic is over there. You can speak. Thank you.
Yeah, hello. Thank you for the very interesting presentation. I was just struck with the map where you were talking about the lack of available data in certain regions. that particularly for the injecting drug use for Africa, it seemed to correlate quite closely with the Anglophone regions. And I was just wondering, in the review, I was wondering whether you know whether it's actually due to a lack of data or just that the data may exist but have been published in different languages, for example, French or Portuguese, and whether that was included in your review or not?
Thank you very much for that question. We searched in all languages. By we, I don't mean me, because I don't know how to search in other languages, but particularly for the grey literature searching online, the searches were actually conducted in a full range of different languages, and any report that came in another language was included. So I'm sure that we have missed reports in other languages, particularly those that are more difficult to find, but we included them where we found them. Yeah, thank you.
Good. We have another question here that comes from Matt Bunn. Did anyone with lived or living experience of incarceration help with grey literature data searches?
That's a very good question, and other than when we were asking people if they were aware, not in our core team, but definitely in terms of reaching out to networks of people, we did send a fairly wide request for any information that people, if people were aware of studies. But we very much welcome people to engage with us and also point out any limitations in what we have found or not found. Definitely welcome that feedback.
Great. Looking out, there's the mic coming perhaps to ask a last question. I have one question actually that I'm asking while the mic is on its way. I'm interested in understanding recent infections actually, because differentiating between whether the infection was acquired in prison or before people were incarcerated. And second question, have you got any information about co-infections, hepatitis C and HIV?
No and rarely. Basically, we weren't looking at incident studies, we were looking at prevalent studies, and there have been some really excellent reviews, particularly for tuberculosis and for hepatitis C, looking at incidents of those infections during incarceration, and I'm sure for other health problems. So that wasn't the focus of what we were doing, but definitely we noted whether or not there were co-infection data, but often not. Yeah.
Okay, thanks.
Sorry, Ashley Brown, UK. Certainly in the UK, and I suspect in a lot of Western Europe, first-generation migrant populations are overrepresented in the prison population. Some of these infectious diseases may not be related to injecting drug use, particularly hepatitis B and to a certain extent HIV. Have you taken that into account by looking at what percentage of the population may have acquired it through non-injecting drug use?
We are aware of that issue. No, we didn't formally do that. And apologies if it sounds as though we're inferring or implying that all of these infectious diseases are either among people who inject drugs or due to people having experienced risk during their injecting. That's not the intent of the review, and that's not what we think either. We're very aware of the fact that there are many ways in which people could have become infected with these different diseases. Yeah.
Good. I think we can go on to the next presenter. Thank you so much again. Wonderful presentation.